Good morning, everyone. I'm going to be presenting to you today about exercise prescription for multiple sclerosis patients. Again, for some reason that I don't know, every time I present, the window over here with my face on it does not show up. So we're just going to go for it. So here we go. First off, we have to define what is multiple sclerosis or MS. It's very complicated, but essentially it's a chronic inflammatory autoimmune disease of the central nervous system. It's characterized by nerve demyelination due to attack by T cells. So your T cells literally attack the myelin around your nerves, and therefore they create these what they call scleroses, these scar-like plaques around the brain and spinal cord that impair nerve conduction and transmission. Okay, so there are a lot of common signs and symptoms, and they're all mainly neurologically related. They include muscle numbness or weakness, blurred or double vision, cognitive dysfunction, balance issues. That's like the onset of multiple sclerosis. Other signs and symptoms: symptomatic fatigue, bladder and bowel dysfunction, not being able to hold that in, and then dizziness, vertigo, and pain, paresthesia, spasticity, and optic neuritis. So those are the defining characteristics of MS and signs and symptoms. Who has MS? It affects a lot of people here in the U.S., about 400,000 individuals, and then 2 to 3 million worldwide. And as you all know, it can be a very painful experience. They don't know exactly what causes MS, but researchers believe it involves an abnormal, like it says here, an abnormal immune-mediated response influenced by a combination of environmental, infectious, and genetic factors. So in other words, they don't know. Usually occurs between ages 20 to 50 years old, so you're more likely to see it in middle-aged individuals. I don't even know if that's considered middle age anymore because I'm almost there. And it's 2 to 3 times more likely to occur in women compared to men. So, yeah. There are different types of MS, and this is what I meant by it's very broad, is that there are different types or stages of it. You have relapsing remitting, which is periodic exacerbations followed by full or partial recovery of deficits. You have primary progressive, continuous disease progression from onset with little or no plateaus or improvements. Secondary progressive, slow and steady disease progression that transitioned from the relapsing remitting type. So first type. And then progressive relapsing is progression from onset with distinct relapses superimposed on the steady progression with or without full recovery. So that's kind of from least severe to most severe. This is the different stages and the characteristics. Here's kind of a scale that we can, as exercise professionals, use that help us know the level of disability in a more numerical sense. So 0 to 2.5, none to minimal disability, 3 to 5.5 is moderate disability, but still ambulatory, can still move around without assistive device. 6 to 7, severe disability, but can still move around with an assistive device. 7.5 to 9 is wheelchair or bedbound, and 10 is death attributable to MS. It's once you get to that point, there's no coming back, and it attacks quickly. The effects of exercise for individuals with MS. So here's just some of the benefits that we can see from exercise. It shows that those with mild to moderate disability, after completing an aerobic exercise program, demonstrate improved VO2 peak, increased fatigue tolerance, because that's a big thing is, these individuals get fatigued very easily, increased walking capacity, obviously due to fatigue, and also just walking is difficult. Improved quality of life and reduction of risk factors pertaining to CVD. So a lot that pertain to the general population, but is especially helpful for this population. Other studies performing 10 sessions of upper body endurance training in persons with progressive MS showed improvement in VO2 peak as well. So that's upper body, because many people don't have use of their lower body. Severely disabled patients can still obtain cardiovascular benefits. So just because They may be wheelchair bound, does not mean that they can't participate in exercise. And increases in isometric strength and power following resistance training programs have been shown in studies as well. So here's some things to consider before exercise testing. Individuals with MS report lower exercise tolerance and higher perceived fatigue because of the demyelinated nerves. Maybe explained due to it can also be deconditioning, lower rates of physical activity, and higher cost of walking, energy cost. Low maximal aerobic capacity, so they usually use less than 60% of their predicted VO2 max, which is very low. Heart rate and blood pressure responses are blunted with persons with MS, so whenever you take heart rate and blood pressure, be prepared for some skewed numbers there. And decreased muscle performance, they have low isometric strength and dynamic power production. That's why, as in the previous slide, we see that these individuals gain isometric strength and muscle power. So here's exercise testing, how you should do it for these patients, these individuals. Definitely, of course, review medical history, list medications, that whole thing. You always want to do that prior to everyone, but especially to know what medications they're taking and kind of what stage they're in this battle. Avoid testing during acute exacerbations of symptoms, which usually happen later in the day, so it's best to actually test in the morning. So just keep that in consideration. Do it in a climate-controlled room because some individuals have issues with thermoregulation. They can't bring their temperature back down. Use RPE along with heart rate since that response is blunted. And cycle ergometry is recommended because it requires less balance and coordination than treadmill walking. So a lot of individuals, like we said, have balance issues. So cycle ergometry is good because it's easier to coordinate arm and leg together. And it's also, you don't want them walking on a treadmill and falling. So here's some modalities of functional assessment. You have the 6-minute walk test for endurance, time 5 repetitions sit to stand. So that tells us their muscle strength capacity. Time 25-foot walk, gait speed. Berg balance scale, it's balance, and dynamic gait index is also dynamic balance. Recumbent stepping ergometer or dual action stationary cycle is suggested whenever we talk about cycle ergometry. Non-ambulatory, so people that can't move around on their own, that have sufficient upper body strength to use an arm ergometer. Obviously, you want to use continuous or discontinuous protocol of 3 to 5 minute stages if you're testing, so you don't want to ramp it up too fast and too much. And each large muscle group should be tested because weakness may present itself in a specific group or limb. There may be a group that has more spasticity than another muscle group and lower antagonist muscle strength. And then also assessment of flexibility, again, due to the spasticity, can't say that word, of some of these individuals. So here's some exercise training considerations. Individuals with minimal disability on that scale have fit principles similar to that of healthy adults. Incorporate functional activities, sitting to standing, walking upstairs, things like that. Consider using RPE of extremities separately. So, on a scale of 0 to 10 or preferably 6 to 20, how's your right arm? How's your left leg? During an acute exacerbation of symptoms, decrease your fit to level of tolerance. Warm up muscles prior to stretching to be most effective via exercise. So we want to warm them up before we stretch. Slow and gentle passive ROM stretching or seated, needs to be seated or lying down due to imbalance. And spastic muscles increase the frequency and time of flexibility exercises. So you're about to see it here in these fit principles. There's aerobic 2 to 5 days a week. So, it's similar to the general population, maybe a day less. The intensity 40 to 70% VO2 reserve or heart rate reserve. So RPE around 12 to 15, moderate intensity. You want to increase your time initially to a minimum of 10 minutes before you increase intensity. You don't want to increase intensity until you can get 10 minutes and then progress to 30 to 60 minutes as tolerated. Prolonged rhythmic activities using large muscle groups, just like for everyone else. If they can walk. If not, arm ergometry is good. Resistance is usually less than the general population, 2 days a week, 60 to 80% of your 1 rep max. So that's going to be, moderate to moderately heavy intensity. Begin with 1 set and then gradually work to 2 sets. Don't start off with multiple sets. 1 set's good, of 10 to 15 reps. Multi-joint, single joint exercises, machines, free weights, resistance bands, or body weight being great for those that are further along that scale. And then flexibility, we're going to stretch a lot more than the average person, 5 to 7 days a week, obviously to the point of tightness or mild discomfort. Hold 30 to 60 seconds of 2 to 4 reps and do static stretching. And again, we may do multiple of these in one day just to help because of the spasticity of muscles. Some special considerations to take into account. Take medication side effects into consideration when testing and training and putting all that in your schedule. You should already have that medication on file because of the medical history. Help individuals with MS understand the difference between general MS fatigue, what they feel on a daily basis, and temporary peripheral exercise-related fatigue, because there will be a difference. There is something called the Modified Fatigue Impact Scale that you could use to help them understand that. You want to encourage individuals to increase fluid intake with physical activity. A lot of individuals don't drink as much because they're worried about bladder control, but due to their some inability to thermoregulate, we want them to drink plenty of water before they exercise. Many with MS have some level of cognitive deficit that may affect understanding of testing and training instructions, so they may have short-term memory loss. So write instructions down, be okay with multiple verbal cues and reinforcement, be okay with saying the same thing over and over. And then this right here, watch for signs and symptoms of the Uthoff phenomenon, transient, which is a transient worsening of neurological symptoms. So visual impairment is the biggest one, and it's associated with exercise and elevation in body temp. So look out for that. If they start to get double vision or vision blurred, tone it back. And then use fans and cold neck packs and provide fluid replacement to assist with thermoregulation. So keep cold packs on hand, keep fans on hand, and have them drink plenty of water. I mean, that's something I think we can all agree is smart. So thank you all so much for listening to me, and I hope that this will ultimately help you with what you're trying to accomplish with your careers.